Thank you, Jennifer. Good afternoon, everyone. My name is Sherry Wiley. I'm the Youth Mobile Crisis Team Administrator here at HCA on the Crisis Systems team. My pronouns are she, her. And I'm going to go over some crisis system legislation and the youth best practice model. Next slide, please. In July 2020, the federal government designated 988 as the number to call for people in crisis, so they didn't have to remember a 10-digit number anymore. As you know, 988 went live in Washington last year, and calls to 988 are being answered in-state by 3 988 Lifeline Crisis Centers. These Lifeline Crisis Centers do great work. They are confidential in nature, and they have an impressive over-the-phone and resolution rate. All other crisis lines remain operational. In 2020, SAMHSA released a best practice crisis care toolkit for adults, and in 2022, SAMHSA released guidance for youth best practices, and NASHBID released its companion report, A Safe Place to Be, which means that we want to stabilize youth at home whenever possible. Next slide, please. In 2021, Washington passed House Bill 1477, establishing the Crisis Response Improvement Strategy Committee, a steering committee, and subcommittees, including a lived experience subcommittee, which has no limit for participation. It also calls for a technology platform and a crisis contact center hubs that will eventually dispatch crisis teams. This year, House Bill 1134 added a geolocation subcommittee and ensured a vote in the steering committee for the lived experience subcommittee. It also created a voluntary endorsement for mobile rapid response crisis teams, which includes youth teams, to receive an enhanced case rate. Teams will get additional performance payments if response times in the bill are met. Next slide, please. Last year, we sent out proviso funding to each of our 10 behavioral health administrative service organizations to ensure at least one adult and one youth team in each region to respond to calls to coming into 988 when it went live. A SAMHSA System of Care grant is supporting MRSS rollout statewide. And Washington has been participating in a national quality learning collaborative with peer state leaders in the youth best practice model, mobile response and stabilization services. For time, I'll be using the acronym MRSS for the rest of the presentation. Next slide, please. This time last year, we only had 4 youth mobile response crisis teams in the state. We've tripled the number of youth teams to 13 and tripled the counties with dedicated youth mobile response team coverage from 5 to 17. These teams are building capacity and have received developmentally appropriate training in harm reduction, de-escalation, and trauma-informed care. And we also put them through an HCA-sponsored Certified Crisis Intervention Specialist 2 training. The System of Care grant is funding an MRSS 101 training, and the team is partnering with the University of Washington for evidence-based practice trainings. Next slide, please. The adult crisis model consists of someone to call, someone to come, and somewhere to go. For youth, we don't want to transport them anywhere. So for youth, the somewhere to go is a safe place to be, sometimes known as a safe place for help. MRSS goes wherever the youth is. Next slide, please. The goals of MRSS are to reduce the use of emergency departments, inpatient stays, and juvenile justice involvement for behavioral health needs. Teams support and maintain the youth in their current living situation. Kids sleep in their own beds. They do this by promoting safe behavior in homes, schools, and communities. And they assist families to access natural and clinical supports. And they break down barriers to care through outreach and engagement with youth system of care partners. Next slide, please. There are 2 phases to MRSS. MRSS meets a sense of urgency with urgency when families call, teams go. They're going to respond with a clinician and a parent and youth peer and provide developmentally appropriate engagement, de-escalation, safety planning, and can help support caregivers in keeping kids safe at home. They can follow up for up to 3 days. Next slide, please. If the family has additional needs or has additional needs or that need additional support, there's a separate but connected in-home stabilization phase for up to 8 weeks. During this phase, they promote safety at homes, schools, and communities, provide psychoeducation, skill building, and work with the family to identify and connect them to community supports. through wraparound principles. Teams will make referrals and provide warm handoffs to the right level of clinical care to ensure connection, thus preventing return to the crisis phase. Next slide, please. Healthcare Authority contracts with 10 behavioral health administrative service organizations for crisis services. The graph on the left shows in days what youth currently get when they access the crisis system. All kids get that crisis intervention phase in green for up to 72 hours, insurance blind. 2 regions are providing the stabilization phase for up to 8 weeks. That's King and Thurston Mason through rated unsustainable funding. This includes some local funding, which creates data issues here at HCA, because if we're not funding the program, the data isn't sent up to the state. The System of Care grant is supporting direct service stabilization in Pierce and Spokane. The graph on the right is the goal. This is the future state that all youth get the full MRSS package. We just got a state plan amendment approved so that teams can provide more than the current 14 days of in-home stabilization. And this goes into effect January 1st, 2024. We also added peers to crisis services. Next slide, please. This is how most families currently access crisis services. All of these people tell parents to take their kids to the emergency department when there's a behavioral health need. When a caregiver calls a crisis line and we don't send what looks like help, they're going to hang up and call 911. 911 is going to dispatch either EMS or law enforcement, and they will be happy to transport to the emergency department, or worse, juvenile justice. Washington State has a well-known adolescent hospital boarding issue. House Bill 1580, passed this year, creates a multidisciplinary team housed in the governor's office to address this. A 2022 study by Mary Bridge Emergency Department in Tacoma found that for youth who went to the emergency department for behavioral health needs that year, 61% of families reported negative functional impacts associated with long lengths of stay at the ED. 33% of youth reported that the emergency room visit wasn't necessary or that it made things worse. And the study concluded that the top possible diversions across all means of arrival to the emergency department were mobile crisis outreach teams at 98%. So we want to shift from a risk-averse medical model that requires evaluation and treatment in the emergency department for behavioral health needs to believing and understanding we can keep kids, even those with some level of risk, safe at home. Next slide, please. Through a recovery lens, MRSS is delivered to the family at homes, schools, and communities. In some regions, people call the provider line or the regional crisis line to access MRSS teams. Anyone can make referrals to youth teams, and they'll respond wherever the youth and family is. If a family is calling a public system for help, they need help. MRSS screens in, not out, and allows families to define the crisis and respond in person when young people, their caregivers, or third parties like schools or law enforcement identify a youth in need. We want the right intervention delivered at the right intensity and at the right time. Next slide, please. This slide shows the regional crisis lines where you can access youth MRSS teams on the left. 988 is in the middle. When you call 988, there are four dial pad options. You can press 1 for the Veterans Crisis Line, 2 for the Spanish line, 3 for the Trevor Lifeline, and all 3 of these are answered out of state. You can press 4 for the Native and Strong Lifeline, which is answered in state. You may remember that 988 Lifeline crisis centers are confidential in nature. And the 988 contact hub in orange that will eventually dispatch teams is future state. There is also a text and chat option for 988. Lifelines may have the goal to resolve as many calls as possible by phone because it seems like this would save time and money and be less invasive to the people we serve. But if families don't get what looks like help when they ask for it, they're going to call 911 or go to the emergency room, which is more costly and traumatic. Next slide, please. This is a quick reference slide on MRSS and what to expect. Remember to call your regional crisis lines to access these teams. Next slide, please. This slide has the regional crisis line numbers listed by region, and the stars represent the locations of youth teams. To recap, I just want to remind you to text or call 988 for confidential over-the-phone support and call your regional crisis lines to access your regional crisis system, including these youth MRSS teams. Thank you for the opportunity to present today.